Ma'am, please start.
Good evening, everyone. I am Dr. Pranuti Jadhav, and on behalf of MahaIP 2025, I welcome you all to first episode of Vaccine Samvad. I request Dr. Amok Shahane, co-chairperson MahaIP Women's Committee, to kindly welcome Dr. Nitin Shah sir today.
Thank you so much, Pranoti, for the kind introduction. Looking forward to today's discussion by our esteemed panel of speakers in Vaccine Samvad. I would like to welcome our convener for today's session, a personality well known by all of us, Dr. Nitin Shah, who is a master in vaccinology, who is also working in Hinduja Hospital. Sir, I would like to welcome you and help us to understand the outline of today's program.
Sure. So I think first of all, I would like to thank the IIP Maha for starting this very unique program on vaccines. And when Dr. Pakmode, Amol, and Minaz rang me up saying that we should start this series, I said right away I was starting to start in January end, but then Dr. Pakmode was traveling, so we will start for the first Friday of every month. So the plan would be at every time we will discuss one vaccine, that is one disease and vaccines against that disease. It will have first 10 minutes discussion on the disease burden as to why we need to prevent this disease. Like today we will have Dr. Sushant Mane speaking on tuberculosis disease burden. Then there'll be almost 55 minutes of vaccine samvad or dialogue between moderator, which will be me, and experts. Today we have Dr. Vijay Evle, Dr. Sumita Nayak, and Dr. Praveen Gokhale as the panelists. Of course, some of you will be introducing them. And then I'm going to have a quiz, only 5 questions. I'll say the question. People can answer in the chat box. That way they'll be sensitized to, read further and learn. So the question will not be related to today's topic. It will be anything on the vaccine. So this is the whole idea. And if the office bearers of the MahaIP agree to continue this every first Friday, then 7th March will be the second session, and I will soon announce which vaccine we will be discussing and who will be the panelists. So I think that in short is the outline for every program and today's program. And again, from bottom of my heart, my thanks to Dr. Pakmode, Dr. Amol, and Dr. Minaz for giving this huge challenge to me.
Amog, you are muted. Amog, you are muted.
Ma'am, please unmute. Ma'am, please unmute. Pallavi ma'am, please unmute.
Oh,
Not able to
Amog
unmute.
ma'am, try now. Amog ma'am, try now.
Yeah, it's unmuted now. Yeah. Thank you so much, Nitin Shah, sir. I would like to now welcome Dr. Sanjay Pakmode, sir, MahaIP President, to speak a few words.
Namaskar. Am I audible?
Yes, sir.
Namaskar. Good evening, everyone. Good evening, respected Nitin Shah, sir, and today's panelist, Dr. Vijay Evle, sir, Dr. Sumita Nayak, madam, and Vikram Gokhale, sir, and also
Praveen Gokhale.
Sushant, Praveen Gokhale, and Sushant Mane, sir. So, sir has said ki it was rather, sir has obliged us by saying yes to this program because we want to share a very good knowledge from the great academicians and expert in vaccinology on the virtual platform. So, in just 1.5 hours, we are going to learn a lot from sir as well as the panelists, and a short piece which is organized at the end of the program. It's again a good interaction between the moderator or speakers and the MahaIPians. So I think it's going to be the very good academic feast for all the MahaIPians, especially the first Friday of everyone. Thank you, sir, for agreeing with the giving consent for the said program, and we'll definitely continue on the first Friday of every month, and the next date will be the that is the Friday of March. Next, and the vaccine, whatever you will tell us, we will make a flyer accordingly and we'll circulate in all the. Thank you once again, sir. Thank you.
Thank you so much, Pakmode, sir. I would now like to welcome and ask Dr. Amol Pawar, Secretary of MahaIP, to speak a few words.
Thank you, Amog ma'am. So first of all, welcome Dr. Nitin Shah, sir, convener of this program under MahaIP. Welcome Dr. Srinivas Kasi, sir. He's there in the attendees. Then Dr. Rajshekhar, sir, Dr. Singarwelu, sir, Dr. Sumita Nayak, ma'am, Dr. Samir Dalwai, sir, our president, Dr. Sanjay Pakmode, sir, then Dr. Jitendra Gawane sir, Dr. Meena Sheikh, and today's, and many of them have already joined. Dr. Atanu Badra sir also consented to join, then Dr. Praveen Gokhale sir, and many others. And also today's speakers, expert speakers, pediatric TB expert at national level, Dr. Sushant Mane, who will be delivering a talk, followed by panel discussion moderated by Dr. Nitin Shah sir, then panelist with Sumita Nayak ma'am. She is from Bangalore. She is uh, president of Bangalore IIP. She is very much in the field of vaccinology since last 6-7 years. We are working together in at Indian Academy of Pediatrics. Then Dr. Praveen Gokhale sir, our executive board member of National IIP this year, and Dr. Vijay Yavle sir, past president of National IIP. So there are some inputs to delegates. You have to be to get a MMC credit point, you have to be life member of Indian Academy of Pediatrics. Then you have to put that details along with MMC registration number, then your name, city name, mobile number, and email ID. And I think sir has already told that there will be question answer session also. So I will request all the delegates to put your MMC detail in the first 20 or 30 minutes only, because later on sir will be asking questions, and then your MMC, your name and the other details, your messages may obscure the discussion. So I would request you to put the your details in first 30 minutes only. So thank you. And today's moderator, Dr. Amuk Shane ma'am, all the best for you to you have consented at the short notice to moderate this session. So thank you, and over to you again.
Sir. Thank you, sir. Thank you for the opportunity. I would now like to request the MAHAIP convener, Dr. Sanjay Deshmukh sir, to welcome the delegates today.
Good evening, all esteemed faculties, office bearers, executive board members, national CIP members, and all the members who are joined, I think, across the Maharashtra and all over India. As a convener for IIP this year, I'm very happy. Our scientific team under leadership of Dr. Meena Sheikh, other dynamic scientific members, Dr. Chate, Dr. Sanjay Joshi, Dr. Manish Tiwari, Dr. Wahag, and dynamic Sanjay Pakmode and Dr. Amol Pawar. We plan this year, we will have a lot of activities, and we are very thankful Dr. Nitin Shah sir. He is always there, and we will assure you next one year will be the biggest academic bonanza on MAHAIP platform. And along with that, there are so many activities in the financial management, in Prideka funds, all activities. So this year we'll make sure it is totally academic front by MAHAIP under presence of Dr. Pakmode, our dynamic Amol, Minaj Bhai. So welcome to you all, and let's enjoy the academic feast today. Thank you.
Thank you, sir. We're really looking forward to today's dynamic session. I would now like to invite the scientific chairman, Dr. Meena Sheikh of MAHAIP, consultant pediatric intensivist at Lilavati Hospital, and who's been my mentor and teacher since my PG days, to start with the proceedings for today's talk and introduce our first speaker.
Well, good evening. It's been respected seniors and dear friends. It's been absolute pride and happy to be here with big stalwarts all around. And cutting short, it's our privilege that Nitin Shah sir has kindly consented to for this particular endeavor, which we believe, it's learning is a continuous process, and learning from the giants is always welcome. So thank you, Nitin Shah sir. Thank you, entire team of Maharashtra IIP, my scientific committee. And we begin with the our sessions. Dr. Nitin Shah sir does not need any introduction. However, I will talk in brief that he is a consultant pediatric.
It is red. It is red. Red. Pass
Yeah.
on. Red.
Okay, pass on. It's pass on. Agree, sir. So over to this. We start with the proceeding outrightly.
Yes.
So
Yes.
may I invite Dr. Sushant Mane, our first speaker, for the proceeding. Again, Sushant has been a promising student right from the JJ's day. He has been associate professor, nodal officer, pediatric at the National Center of Excellence for Tuberculosis, Department of Pediatric, in charge Pediatric Asthma Division, Grand Medical College, and Hospital, Mumbai. He's an subject expert in pediatric pulmonology, pediatric tuberculosis, asthma, and sleep medicine. He's a subject expert at national, international level, national technical expert in WHO and other organizations. He has a good record of publications of 53 plus and faculty for more than 140 um, uh, conferences and CMEs. So with this brief, may I invite our own Dr. Sushant Mane to start his proceeding. We'll be talking about disease burden of tuberculosis. Over to you, Sushant.
So
Thank
still
you, sir.
Sushant will load his slides and share. Globally, 1.7 billion people out of 8 billion that exist are infected with TB, and if nothing is done, 5 to 10% of them will progress. That's huge, and no wonder we have 1 million children infected with TB every year. And we talk about elimination of all TB outbreaks by 2030 and mortality reduction by 90% by 2035. But the rate at which the TB is reducing by 2% per year, that's a far dream. Something needs to be done drastic. So I think that's why I chose TB as the first topic for the Vaccine Samvad. And I'm very happy to have Sushant, who is really the maestro of pediatric TB. Over to Sushant. Next 10 minutes, please throw some light as to why TB is so important that we are discussing is the first topic.
Good evening, everybody. At the outset, thank you, Nitin sir, for giving me this opportunity, and Sheikh sir, because they are the two main persons of this CME. And also, I thank President MAIP, Dr. Pakmode sir, and my dear friend Amol for having me today in the first inaugural session. So, when we talk about burden of tuberculosis in India, we'll be just talking next 10 to 12 minutes. Day in and day out, we read such articles in newspapers that, extrapulmonary TB is coming up, especially spine TB has come up again. Important cause of infertility in women is again TB, 30 to 40%. We are bearing the highest TB burden in the world. Drug resistant TB is going up in India. And as far as children are concerned, that is pediatrics, still more than 50% of the cases go undetected. What is going wrong? I mean, it's a point to think, as Nitin sir has truly started the discussion by saying what is going wrong. The rate of decline is only around 1.8%, where if we want to meet the global targets, the rate of decline should be anywhere between 7 to 8%. So when we talk about what is going wrong, this is some of the things what I could collect for today's presentation. So diagnosis is difficult. We know it is very difficult to get a diagnosis because the symptoms are non-specific. The sample collection is difficult. The referrals are many times late. In a country as big as India, there are so many parallel specialities going on, not only in medicine like surgery, orthopedics, and so on, but also what you can say the traditional medicine specialities like Ayurveda, homeopathy, where the knowledge may not be there when to refer the patient. The prescriptions are varied even for TB. We are actually collecting a data in our hospital in the past 6 months. What data we have collected only in Mumbai in the past 6 months, who the patients were referred to us, we have seen as many as 18 to 20 different prescriptions for drug sensitive TB. So, something is somewhere is going wrong. We don't have adequate indoor facilities as far as pediatrics is concerned. Patients, if they are not aware, they are lost to follow up. There is a gap between the private sector. Now, as far as Mumbai is concerned, we are able to bridge this gap. But if you see the entire country, many of the times in private sector, people are hesitant in treating a case of tuberculosis. More so if the child happens to be a case of drug-sensitive tuberculosis. And not last but not the least, the invention of new drugs. Bedaquiline was introduced for treatment way back in 2016. Rituximab was and delaminate were introduced somewhere around 2019. But if you see the drug chart of tuberculosis, since the last 8 to 10 years, we have not had any new molecule which has come up to treat tuberculosis. Similar is the case of vaccines, that is the preventive modality. And that is where our fight against tuberculosis has, attained a standstill. If you see the global TB report, which was released by WHO, around 10.8 million cases were reported in 2023, of which 25.5 lakh were from India itself. 1.2 million deaths, out of which 1 lakh deaths from India itself. And if you see the MDR TB, out of the 4 lakh cases which were reported, around 65,000, that is 1/6 of the deaths, were from India itself. Now, this figure may not seem a little startling, but when I go to the next slide, this is the WHO TB map, which is published every year in their global TB report. Now, this is the blue dots which are seen all across the map are actually the areas of high burden. So if you see the left-hand side, the incident cases up to 1 lakh, up to 5 lakh, up to, something like that. So if you see, the dot is the largest for India across the world, which means India constitutes the highest number of TB cases across the globe. Now, this is a very much matter of concern. So there are 8 countries which are bearing more than 2/3 of the load of TB, but India stands on the top, that is 26%. And if you can see, the gap between the first and the second country is huge. The second in line is Indonesia, which is reporting just 10%, and then it goes on decreasing. To add to this, we are also contributing to more than 27 to 28% of drug-resistant TB burden. So we are top even in drug-resistant TB, which is natural, because if the total number of TB goes up, drug-resistant TB also goes up. Now, when you see about trends of TB in India, specifically for our country, so this is the general notification. This is not specific for pediatrics. If you see, from 2017 onwards, we are getting a steady increase in the number of populations. Never it has dropped except for 2021. This is because of the post-COVID year. 2020, there was COVID and all the machineries collapsed all around the world. And therefore, the notifications went down in 2021. But otherwise, again, after 21, if you see, there has been a consistent increase in the number of TB cases reported. Similar way for the TB deaths. If you see, the death rate may look constant at 4 to 5%, but if you see the absolute numbers, 2024 reported around 1 lakh deaths in India because of tuberculosis. So mind you, these are the cases which are notified to the program. We can imagine how many of them are actually unnotified, which goes, undetected by the program. Now, if you see the DRTB, again, the same picture is there. DRTB numbers are progressively rising as far as our country is concerned. And if you see, the most worrisome part is almost 80%, or I can say 70% of this population is between the 20 to 45-year age group, which is actually the core productive population of the country. So imagine what a loss entirely to the nation we are facing, because this population is going out of business for that long period when they're suffering from TB. 6 months if it is a drug-sensitive TB, maybe a year or more if it is a drug-resistant TB. Now, when we talk about pediatric TB, again, the rate of pediatric TB has remained constant at 6 to 7%. But then if you see the absolute numbers, it started from 1.1 lakh, 1.2 lakh, and in 2023, around 1.5 lakh, that is 1,43,000 cases were reported only in pediatric itself. And if you see the drug-resistant pattern of the children, out of the 65,000 or 64,000 reported from India, around 3,200 were reported in pediatrics. And if you see the spectrum, you have all the spectrum in pediatrics. Majority is obviously the MDR or RR-TB, but we also have a lot of pre-XDR TBs. We have a few of XDR TBs and quite a lot of H monoresistant tuberculosis. Does that mean we can never end TB? No, it is not the thing. So Central TB Division, that is Government of India, introduced the end game approach in 2017 to 18, which rests on 4 pillars: detect, treat, build, and prevent. So detect means we have to upgrade our knowledge to detect more and more cases of TB. Once we detect the case, each and every case which is detected should go on the appropriate treatment. This can only happen if we build not only the infrastructure or the lab support, but build our knowledge, build the number of physicians, not only in medicine specialty, but medical, surgical, everybody joining hands. So build a manpower to tackle all the cases. And last but not the least, prevent. So this is our point of discussion today. When we mean prevention, as we know, there is primary prevention, there is secondary prevention. So primary or primordial prevention, which we are going to discuss today, is what about vaccines? Till now, we know that BCG is the only vaccine which is highly effective and being licensed for use across the globe. Then we have preventive therapies which have come up, that is TB preventive therapy, which has been implemented along, across the world. So with that short introduction about the burden of TB, I would now hand over the future proceedings to the extreme panelist. Thank you for a patient listening.
Brilliant, Sushant. Can you stop sharing your slides?
Yes, sir.
Yeah, I think this is very scary. And Ms. Sushant spoke of prevention, saying either primary prevention by vaccines and other measures and secondary chemoprophylaxis. But it is so sad to know that only 13% of eligible children who are in contact with the TB patient actually received the correct prophylactic therapy. No wonder you see a lot of innocent bystander children getting TB from their contacts, and many of them are exposed to MDR, and that's the problem. So we come to prevention, which is primarily by vaccination. That is the topic for today. So we are not only discussing BCG, we are discussing TB vaccines in general. Of course, BCG is the mainstay, but there are some exciting news about other vaccines too. So now I will start the panel discussion. We have no PowerPoint, it's just question answer. So the screen will remain as it is. We have Dr. Sumita Nayak from Bengaluru. She has been already introduced. And for some of you who are attending the IAP vaccine course, you will know her very well. She's the one who is coordinating all that. Dr. Praveen Oakley is my dear friend from Thane. Now is the representing IAP from the MMR region. Welcome, Praveen. All the panelists can please unmute yourself forever so that you can in between also answer. And last but not the least is Dr. Yevle. No vaccine session can end when I am there without Dr. Yevle being there. So let me start with the BCG first. Unlike a lot of people who think BCG is a useless vaccine, because we have all been taught in our brain as a pediatric training that Chingalput trial showed that it doesn't work against adult TB, and I think that's the myth we need to dispel today. And let's start with some rapid fires about the BCG, some practical aspect before we go to the different theories. So first, let me ask Dr. Sumita. WHO and the product says 0.05 for below 1 year and 0.1 ml for above 1 year. Is it possible to give 0.05 ml exactly to a baby who is crying and the pediatrician who is even struggling more?
Good evening, and thank you for having me on this panel, Dr. Nitin Shah, Dr. Vijay Evle, and the entire team, Dr. Pakhode, and Team Maharashtra for having me here. So actually, this point about 0.5 ml or 0.1 ml, first of all, the debate has come up because in the initial days, it was a 0.1 ml which was being given.
Correct.
And along the way, it was found there have been a lot of studies and lot of papers which talked about the how 0.1 ml was better than 0.5 ml in terms of its effectiveness and the conversions, etc. But along the way, again, there were further studies to show that the 0.5 ml itself gave
0.05.
Sorry, 0.05 ml itself gave adequate protection. So
no, my question is,
yes.
That's right, but can you actually give only 0.05 in a struggling child and a struggling doctor?
Well, I think we have to be trained enough to be able to withdraw. So even if you withdraw 0.1 ml, you have to make sure that you're giving only 0.05 ml until the age of 28 days. That's what ACVIP recommends, that we give it for the first 4 weeks, 0.05 ml, post which it is 0.1 ml. So
what if I say that I give enough to create a wheel of around 5 to 6 millimeter, and that I know adequate has gone? Because when you're giving, something will leak, something will go out, so it's become so difficult to give exact amount. Is it good enough I say 5 millimeter small bubble and I know I have given it correctly?
As you get the experience, probably you come to understand that yes, you have given it adequately, and that's the amount which was adequate in the newborns to give you the best response with the minimal amount of side effects.
Okay, Dr. Yeble,
So
what if it goes
subcutaneous? Practically, you have that lyophilized powder and saline as the diluent. When you dilute, it makes more than one dose. It's a multi-dose vial even in private sector.
Yes,
so,
yes, sure.
So you withdraw in that tuberculin syringe, BCG syringe, and raise a bleb of 5 to 6 millimeter. It is practically impossible to measure 0.05 ml.
Okay, point well taken. What if it goes subcutaneous, Dr. Yeble? It many times happens that you have injected and it goes subcutaneous.
See, only the risk of adverse events would increase if it goes
like
lymphadenitis and local reaction as well. Otherwise, subcutaneous reaction also can lead to good uptake and scar formation.
Perfect. Dr. Praveen, some mistakes, I get a phone call every month that in the newborn, while giving hepatitis B, BCG and oral polio together, someone injected BCG 0.5 ml intramuscularly and hepatitis B 0.1 ml intradermally. Now, mistake is known. So, number one, will that hepatitis B work when given intradermally 0.1 ml? But more important, what will happen to that 0.5 ml which has gone intramuscularly?
Yeah, this is definitely an error of medication, because it is ideal when you are giving hepatitis B and BCG together to use two different type of syringes so that you can really differentiate. what you have drawn in the for the BCG and what you have drawn for the hepatitis B, and keep them separately, ideally label them. But I think even different syringes would do. If you give the hepatitis B given intradermally won't really work. We'll have to give it intramuscularly for it to enter the muscle and start working. For the BCG, if you have given BCG intramuscular, it can be drained to the through the local lymphatics to the, it can cause a local abscess, or it can go into the systemic circulation, and it's a live attenuated vaccine. So just like any other live attenuated vaccine given intramuscularly, it has its own side effects and it should be avoided.
So it will lead to a abscess, cold abscess, most likely 99%, but don't have to worry. You treat it like any other cold abscess. Don't have to give AKT. You may do repeated aspiration. We'll come to it a little later.
But Nitin, this is not a theoretical worry.
No, it's a practical step.
It keeps happening, and last 3 weeks there have been back-to-back 2 cases, even at a private corporate hospital.
Absolutely.
We had so much so that we had to take a special session to the staff nurses on the floor to use different syringes.
Correct. So I think best is to make one vaccine, give it before you make the second vaccine. It's not only true for BCG Hep B, but also for your pneumococcal. People have diluted HEP in pneumococcal, and all sorts of permutation and combination. I mean, vaccination is our prime practice, which is remaining in pediatric. And if you don't spend enough time even for that, I think there's nothing
just a quick word, since I came across this problem. Many times it develops cold abscess. You do IND, you aspirate that person, and it is sent for gene expert. Mind you, gene expert would detect MTB complex, which also includes BCG. So Bovis. So invariably, many pediatricians or practitioners get confused and tend to start anti-TB therapy, which is not required in the BCG abscess. Number 2, injection site abscess can also occur with extremely rare, not so common, with Mycobacterium tuberculosis, and what is more common is NTM, non-tubercular mycobacteria.
We'll come to that later. Yeah, sure. Vijay, point well taken.
One more error I would like
but that
to
need not be
out,
that need not be only BCG given wrongly. It is actually any injection precipitating a tuberculosis abscess. We are not discussing that. That's the part of TB disease. Let's come to Dr. Sumita. A lot of high-five people say girl child, she doesn't want the scar to be seen. Please give it on the thigh. What are the dangers of giving BCG on the thigh?
Well, sir, again, the skin there is definitely, you have to be very, very careful to give it, ensure that it goes intradermal, because the chances of it going deeper, and as Dr. Yevle sir just mentioned, it could go intramuscular. And then you have a much more painful lesion there. It could cause an abscess. There could be the BCG lymphadenitis, which happens, which is much more common in the thigh region if it is not given properly. So that is the challenge there.
My worry will be also that if it leads to BCG lymphadenitis, which can happen in 1% of children who receive BCG, it may be deep inguinal lymph node, which is so difficult to treat. So never ever give. I mean, you tell the patient, go to hell. I don't come to me. I'm not going to give you on the thigh. And of course, sorry for the ladies here, but I always keep on saying that the apparels for the girl child is becoming so smaller and smaller that however higher I give BCG is going to be seen the scar even on the thighs. So I mean, that convinces them, saying that, okay, the side effects are a problem. Dr. Yevle, BCG is open. The diluent falls. Now the pediatrician doesn't want to waste it. Can he use any other diluent?
No. BCG has a specific diluent of normal saline, 0.9 normal saline. So it cannot be, distilled water for injection cannot be used.
All right. Dr. Praveen, I have diluted BCG given to one patient. Now another patient is coming in the evening. Can I keep that vial?
No, the recommendations say that once you have reconstituted the BCG vial, multi-dose BCG vial, it should be protected from light, kept in a cool environment, and used within 4 hours of reconstitution.
Correct. So maybe the same immunization session, but not beyond that.
There is no open vial policy for the BCG vaccine.
Absolutely. Okay, Sumita, what if a scar is not seen at 3 months?
Well, as we know, there is about 10 to 12% of the children, when everything is correct, technically everything is proper, who do not develop a scar. But the absence of a scar does not indicate that the vaccine has not been taken up. So adequate number of studies are there. Now, it is conventionally thought that up to 6 months is the right period to wait, because there can be a reaction up to 6 months and the development of a scar. So
suppose 6 months there is no scar seen. Now what do you do?
Yes, if there is no scar seen at 6 months, you can, if the parents are anxious and you want to ensure that it's rightly identified as the child has been vaccinated with BCG, you can go ahead and repeat it one more time. So that's it.
So that's where the dichotomy is between IAP, ACP, VIP, and WHO. WHO says that 10% children who do not develop scar, and only 10% of the 10%, that is 1%, actually do not have a lymphocyte migration inhibitor test showing that there is immune response. So for that one child who is not responding, you cannot give other remaining 99 second BCG. But the ACVAP says maybe because in our country BCG is given at randomly by many people, so may not have been the correct process followed. So maybe you can give the benefit of doubt by giving the second injection, but don't give the third injection if the scar doesn't become evident after the second injection. Am I correct, Dr. Sumita?
Yes, sir. So just one more time, you may repeat it after 6 months if no scar is seen. Yes, sir.
All right. So we have 470 people, as I see, on participants here on the Zoom, and there will be many on the YouTube. First question, let me see how many of them are actually attending, or they are attending only for that one MMC point. So I'm going to ask you one question. You can put your answer in the chat box. As I said, this quiz question has nothing to do with today's discussion. So the question is, which vaccine is available internationally for monkeypox? I repeat, which vaccine is available internationally for monkeypox? And I think I'll give the answer after maybe 5 minutes. We'll continue with our questions. So the next question, Dr. Vijay, you were mentioning about BCG abscess, NTM abscess, etc. Forget the NTM abscess, which is a TB abscess, not related to BCG, but any injection which is given intramuscularly. Specifically, BCG lymphadenitis. How do you treat? AKT, abscess drainage, leave it alone, aspirations, what do you do?
So BCG lymphadenitis is not an uncommon side effect of BCG vaccination. However, it does not require any anti-TB therapy. If it is a non-suppurative one, it recedes over a period of time without any treatment. You need to keep the child under surveillance to see if it caseates and forms abscess. If there's a liquefaction, then you can either do repeated aspiration or do IND. But again, that's the end of therapy. No anti-TB treatment is required.
Absolutely. I think repeated aspiration is simple OPD procedure, not even an IND, which we need probably a GA. Dr. Kasi was here. I'm sure he's still there somewhere in these 471 people. Welcome, Dr. Kasi. So a non-dependent aspiration from the top, so that there is no formation of a scar, sinus, or a fistula.
And use a Z technique. Stretch the skin
using a Z.
so that it does not form a linear sinus. There is
All right, Dr. Sumita.
Yes,
rare, but definitely we know there's something known as BCGiosis. What is this BCGiosis? If you can throw some light.
Well, this is BCGiosis is a very, very specific condition which can occur, especially in those who are immunocompromised in the infants. And there are very definite criteria. So there are 3 criteria for defining it as a BCGiosis.
Yes.
The first of all is you have to be able to show that there's you should be able to isolate the organism. That's the first thing. The second thing is you have to have a multi-system involvement. Therefore, you have to be able to show again the presence of the organisms.
So spread of the BCG from the primary site to distant sites.
Distant sites, yes.
Right. And the third criterion?
Of course, you need to have the systemic symptoms such as fever, weight loss, etc. So
or hepatosplenomegaly.
So the presence of these 3 criteria is what defines it as a BCGiosis.
So you have a very sick child who developed BCGiosis, that is probably either HIV infected child, though rare in our country now with a very strong PPTSD program. More likely the child probably of a severe combined immunodeficiency or SCID. If you have otherwise well-looking child with BCGiosis, then think of what is known as MSMD, the Mendelian susceptibility to mycobacterial disease. We will not discuss further. The incidence is very rare, 1 to 4 per million doses. But if there is family history of immunodeficiency like picture in previous children, you should refrain from giving BCG to this child. Till the time, at least you do a CBC and look at the lymphocyte count. Because kid children usually will have a very low absolute lymphocyte count. So any count below 4,500, you further investigate before giving the BCG. All right, Dr. Praveen, we discussed the BCG. We give only one BCG, but there are some countries which give a second BCG. Any role of repeat BCG as a booster?
Role of repeat BCG of a booster is not really there, because as the age increases, the efficacy of the BCG vaccine is less.
Correct.
So as Dr. Sumita has earlier said, that if at all you want to give a second dose, it should be early on in life rather than late. But there are certain situations for the late first dose of BCG, like for children who have not received any BCG vaccine in developed countries who are coming to India. But for second BCG dose, I don't think there is any indication.
There is no role of repeat BCG. Okay, we'll come to that little later because we are going to discuss the BMC program of adult vaccination. So we'll come to that. But the only advantage of a second dose of BCG is prevention of leprosy. There it's shown that if you are given 2 doses, leprosy becomes lesser by 50%, especially in a person who is in contact with a leprosy patient, giving a BCG has. But of course, leprosy is so rare in our country that probably we may not discuss that. All right, now we come to the question that I was saying, and maybe it's Sumita, I don't know whether it's there in Bangalore, but the local, I mean, Indian level, there is a move to give BCG to adults.
Yes, sir.
So anyone above 60 years, anyone who is diabetic, anyone who is a smoker or alcoholic, or someone who has had TB in the past 5 years, or someone who is obese. These are the people who have been said to take a BCG. I mean, what is the funda of giving this BCG to adults, and what is this? What are we trying to prove?
So here, this is again, it's in a programmatic mode. I think it's across 23 states in the country currently. And
Right.
as you rightly mentioned, there are 6 criteria there. One of it is also having a very low BMI, that is less than 18 kilograms per square
Yes.
meter is also another
Correct.
criteria for enrollment. So it is totally voluntary enrollment that is being looked for. This is a program by ICMR. The idea here is to see whether by giving this BCG, the population which is actually prone, the high-risk population, the 6 criteria that we mentioned, whether they can be protected from pulmonary tuberculosis subsequently. So the
Perfect.
endpoint there is the development of the pulmonary tuberculosis, and this is still in a programmatic mode at present. And as I said earlier, it is a voluntary enrollment that ICMR is undertaking.
So there are several studies in the past which have looked at giving BCG to adults to prevent pulmonary tuberculosis, but none of them have actually shown absolutely any benefit. But no one has done in a programmatic manner. People have all done in a controlled trial or a observation study. So this is a huge, experiment taken by the ministry in India, where I'm sure lakhs of people will be given adult BCG. And if they are followed up over the next 2 years and see how many of them actually don't develop TB vis-a-vis the control, then it will be a path-breaking study from India, which may open the Pandora's box to say that, okay, we make you a second BCG adult. We will very eagerly wait for that result to come. But
Nitin, I remember Sushant
yes,
talked to me once saying that this is a desperate attempt to bend the curve. We are
doesn't matter. That's
committed to
perfect.
eliminate, but they have shown that the modeling shows that it can reduce the reactivation of disease by almost 17% if you.
But that was statistically
identify.
not significant. It was -2 plus. So that's the reason why. So
Yeah,
it'll be a good thing to see
in a
what
program,
happens.
let's
Of
see
course, people
what
took PCG as an immunomodulator during COVID time. A
COVID
lot of
times,
people took. It
yes.
was proven in not 1 but 4 studies that it did not do a dent on the COVID infection, whether you took or you didn't take BCG. So I think we'll rest it there and we'll await the results. Okay, Dr. Vijay, HIV infected child. In past, WHO said no, then now says yes. SCVIP says yes. What is your take on HIV exposed child, whether he can be given, an HIV infected child, whether he can be given BCG?
So HIV and tuberculosis, they are closely linked with each other. Now, the population where HIV is endemic, TB is also endemic, the benefits of giving BCG far outweighs the risk of this baby developing HIV later, because most of these babies are immunocompetent at birth. However, there is a school of thought which says that babies who are immunocompetent at birth, who are born to HIV positive mothers, when they dip in their immunity, there is a risk of development of BCGiosis or disseminated disease. So there was a recommendation once in the past that HIV exposed babies born to HIV positive mother, the BCG should be deferred.
But
Now,
that was essentially in Africa, where
Correct.
ART was still not the standard of care.
Correct.
With
Correct.
the starting of ART very early,
They have
every
withdrawn
HIV
that.
infected. Now, so what is the current
Current
scenario?
recommendation is in places where you can establish the diagnosis of HIV infection, the newborn, you may defer it until you start this baby on ART. Otherwise, the universal recommendation is go ahead and give BCG.
Yeah, so and his CD4 count should be appropriate for the age, which is more than 25% for below 5 years, or more than 200 if the child is above 5 years. So please do not say no. Okay, one more question, Vijay. Can you give it to preterm baby? Initially, we say 2 kilos for hepatitis B. BCG also may not work at very young age. Extremely preterm. What is the?
No, most of the preterm babies who are stable hemodynamically stable and off life support, they can definitely be administered BCG. Because
Okay,
this is one opportunity where
yes.
you can catch them and give BCG.
So
Otherwise,
do not differ BCG,
no,
even
no.
do not differ hepatitis B. That a criterion of 2 kilos and all is now given up. So because we are giving 3 more doses of hepatitis B, after that is 6, 10, and 14. And in private sector, you also give maybe the 15-month booster also, which is hepatitis B containing vaccine. So you should not deny to any baby born who is like not sick, is steady enough, stable enough to take the doses, should be given the vaccine. Okay, next question, Praveen. What about the mother who is having TB? Should you give BCG at birth, or I mean, you investigate and defer, or what do you do?
No, the baby who is born has to be given BCG vaccine irrespective of whether the mother has active. It's a different issue altogether if she is HIV positive. But
No,
otherwise,
not HIV positive. So
I'll
the
go
standard
ahead
of
and give the BCG vaccine.
so standard of care is that if the baby is exposed to mother who is having is on AKT, you should first rule out that the baby is not having TB by doing quick test. And if he's certain that he's not having active TB, you should put him on the prophylaxis for 3 months, which is a double drug. And then at the end of 3 months, again, you're certain the baby is still not infected in the incubation period, and then give BCG at that time. So you may defer it by this type of algorithm. Praveen, also the question, are there any true contraindication to BCG?
The only contraindications are the immunodeficient conditions,
Right.
but which are very difficult to determine immediately after birth. But there are
Correct.
certain situations where the elder sibling is having immunodeficiency.
Mhm.
There you can be a little bit careful to see that the newborn is not having that condition, because there are various tests that are available now. So this will apply only to immunodeficient conditions which are known. Otherwise, I would be like thinking too much. I will go ahead with the BCG because it's very difficult to determine advance.
Absolutely. Answer to the first quiz question, some of you have given in the answer in the chat box. Yes, it is Jynneos containing the live modified vaccinia virus Ankara Bavarian Nordic strain. It's a very different strain, what is known as MVABN. It is only licensed for above 18 years as 2 doses 1 month apart. It is not 100% effective. It is around 70 to 80% effective. Basically, is used against smallpox, but is also now used for the monkeypox. I'll put the second question and then we'll continue the debate, I mean the BCG dialogue.
So can I add something there
yes,
for the
please.
contraindications? There's the mother on biologicals, especially the long-acting ones, is like rituximab. In those conditions also, you have to defer and give the BCG late.
Yes, 6 weeks, right? Because the drug could have passed on transplacentally. All right. The second quiz question for all those 480 people who are still actively participating: who invented rabies vaccine? I repeat, who invented rabies vaccine? Please put your answer in the chat box and we continue with our BCG. Dr. Sumita, mishap in corporate hospital, BCG was ordered, nurse gave onco BCG. What is onco BCG and what will happen to this child?
Well, yes, Kasi sir is there. So Kasi sir is...
Bangalore 3 times it has happened.
Yes.
Bombay once it has happened.
Right. Kasi sir has had the experience there. So the onco-BCG is actually used as a treatment for bladder cancer, as an intravesical installation for bladder cancer. The preparation is the tuberculous bacilli, which is 100 times more. So you have anywhere between 1 to 19 into 10 to the power of 8 colony-forming units of the organism.
Right.
So you are giving, whether you give 0.05 ml or 0.1 ml, you are giving at least 100 times higher, 80 to 100 times higher doses. It's a mishap. So you are definitely going to be needing to watch out for the adverse effects in terms of the BCG lymphadenitis. Yes.
And massive ulceration.
And
all right. The treatment
ulceration,
would be the same as any BCG lymphadenitis. No AKT, repeated aspiration as required. So please, when you see that it's not onco BCG and it's the normal BCG. All right,
There is a beautiful, Nitin, there is a good series of about 26 or 28 odd cases from Bangladesh, where they have...
Pakistan, sir. Pakistan, Aga Khan University.
They tried using INH, but which is not recommended. Apart from increased risk of adenitis, nothing happens.
Yeah. Okay, so one drug that you will never use in a BCG scenario, of course, you don't use any AKT, is pyrazinamide, because BCG and Bovis is inherently pyrazinamide resistant. Okay, we'll leave it there. Dr. Praveen, I've given BCG and someone has done a Mantoux test. Nowadays, Mantoux test is gone out of vogue because the original Mantoux test reagent is not available. And now we have a much better way of diagnosing. You can either do an IGRA or you can do a bacillary investigation by in the form of gastric lavage, sputum, etc. And now a lot of research is coming on stools for gene expert in patients suspect to have a pediatric patient with TB. We'll come to that a little later. But does it, if you have done a Mantoux and it's positive, is it because of BCG or is there any cutoff or how long the Mantoux can remain positive after BCG?
So after the administration of BCG, the Mantoux test can remain positive over a variable period of time, and it is very difficult to determine whether the positivity it is due to the illness or due to the sensitivity due to the giving of the BCG. So it's very difficult to determine whether it is a illness pattern or a normal routine hypersensitivity sensitivity pattern due to BCG vaccine.
Usually it
So
will
you
not
cannot
remain
interpret
above,
it as an illness, basically.
yeah.
Beyond
Yes,
1
it says that up to 5
It says that the
millimeters
test
because
is,
of the non-mycobacterial tuberculosis exposure, up to 10 maybe because of BCG, but about 10 or about 6 months since BCG usually is not because the BCG is. But if, anyway, as I said, we don't do Mantoux test. So that brings me to the question to Vijay that you don't do Mantoux test, but now you have a very sophisticated intradermal test is as good as doing an IGRA, but much simpler and safer. That is known as CYTB. So what is the CYTB test, which is like a new version of Mantoux?
So CYTB is improvised or modified version of CTB, which is a TB test, another tuberculin skin sensitive test, where two antigens are used, ESAT6 and the CFP10, these antigens. So this has replaced the exhausted PPD, and it is now manufactured or marketed by Serum Institute of India, and it has been recommended by WHO. The difference between the Mantoux test, conventional PPD, and the CYTB is the cutoff is taken as 5 millimeter. Since it uses these two conserved antigens,
specific antigens,
they are specific to mycobacteria. So your BCG has less of interference with this.
Absolutely.
Otherwise, the methodology, everything is as like you do for PPD.
It's available as a 10 dose per vial, and each test will cost around 600 rupees. So it's not as cheap as Mantoux test, but much cheaper than doing IGRA, and no blood collection is required. So probably we should be doing this. My Lab, which is a subsidiary of Serum Institute, actually markets it and is easily available. Okay, now the most important question, Dr. Sumita, what is the benefit of BCG in children?
Well, as we understand, it is not a protection against the, it doesn't give any immediate protection to the child against tuberculosis. But the benefit is still there for the severe effects of tuberculosis, which occur usually later in life in terms of the disseminated tuberculosis, tuberculosis meningitis, and miliary tuberculosis. So
almost to the tune of 90%.
Almost, yes. And in low LMIC countries, well, this is the best way of protecting the child.
Correct. What about the benefit to adult? I mean, when the child become adult, I mean, people say after 5 years there is no point in of BCG protecting, but that's not true anymore. A lot of meta-analysis on pulmonary TB, on severe forms of TB, even in adults, has been found that it does protect. So, you can throw some light on those studies.
Well, the follow-up of the famous Chingleput study has also been done, and that itself shows that there is about a 20 to 27% protection, which is still there in the adults. So that was the huge population of Chingleput, which had been studied with BCG back in 1968. So that 15-year follow-up itself, I think this is a very, very significant study, which does show that there is definitely a benefit.
There is actually a very recent meta-analysis of some 18 randomized controlled trial of neonatal BCG and effect in the adulthood for pulmonary TB, and shows there is 59% reduction. So it's not as good as just giving water. In older child, if you are given a BCG, not as neonate, but who is DST negative, which means he's still not exposed to TB, there is still 75% protection against adult TB. Same is done a meta-analysis of cohort analysis, which shows that the prevention is up to the tune of 50 to 80%, depending on which study you look at. And case control trials also show 55%. My guess is around 60 to 65% reduction in pulmonary TB in adults who have taken BCG either as a neonate or before they are exposed to any other organism. And as you very rightly said, for the baby, of course, it's life-saving because it prevents severe forms. And I was recently studying because I had to do this webinar, and I came across this study which actually looked at efficacy against IGRA conversion. That means you don't have developed disease yet. You don't only develop infection. And that also reduced significantly to the tune of 19%. So which means there is a role of BCG and it's not as bad a vaccine as people think. We must very, very aggressively, actively propagate to give BCG to every baby who is born. So that brings to the question, Dr. Vijay Yevle, how long does the BCG protect? We said 5 years, maybe in adults.
As a thumb rule, definite protection up to 5 years, but up to 15 years, the protection does last, especially against severe form of TB, which of course with the increasing age goes on reducing.
Correct. So there are studies done in USA in adults. They have shown up to 60 years benefit going on, and two studies very recently done in one in Norway, one in England again showed that the efficacy definitely persists till 20 years by a neonatal BCG against pulmonary tuberculosis. So it's not that BCG doesn't protect for long term; it does protect for a long term too. Dr. Praveen, if a child comes after 5 years, you alluded to this, then it's not a repeat BCG, but an older child who has missed BCG. Till what age will you give BCG to for a child? Now the mother suddenly says, "Oh, I have not taken, I won't." Or someone has come from say UK, USA, where they don't give BCG. Now they're going to stay here forever. So what do you do?
Up to 5 years, definitely we can give the BCG to any child who
Praveen,
has
can't
come
hear
from
you.
abroad.
We have lost you.
Up to 5 years,
yeah.
you can definitely give for a child who has come from abroad. But above
Mhm.
5 years, I don't think there is any requirement for BCG for this child, because with increasing age, against the efficacy of BCG is shown to be reducing as the age increases.
Correct. If you actually see the UK website and say about BCG for migrant children, they say if someone is going to stay for more than 3 months in a country like India, or is going to migrate forever, up to 18 years child or a 17-year-old child, they would actually give a BCG or ask them to take a BCG after reaching the hospital. So there is a role to give it even above 5 years of age. We may or may not do Mantoux test, but at least you may do what do you call a IGRA in an older child, so that is not already exposed, then there's no point in giving BCG. Okay, Praveen, you can also take this question. I mentioned about leprosy. The other advantage of BCG is against leprosy. You can throw some light on how it helps.
It helps again the M. leprae and M. tuberculosis are organisms which are related to the same family. However,
Correct.
you have to be careful in not giving it to a person who has some type of a leprosy, because it can aggravate the illness in that person. But to the close contacts, I think there is
Yes.
a role to protect them from development of the M. leprae
Yeah,
disease.
in fact, that protection is to the tune of 90%. So that brings me to the answer to the second question. All of you very rightly said Louis Pasteur in 1885 actually invented rabies, where he took rabbit spinal cord, inactivated, and then gave repeated injection to a 9-year-old Joseph Mister, who was the first child ever who was bitten by a rabid dog, would have certainly died of rabies, and he survived. So that brings me to the third quiz question before we continue with our discussion on TB vaccine. The trivalent influenza vaccine is likely to come back soon from the next southern vaccine as per WHO. Which is the strain from the quadrivalent vaccine which is omitted in the trivalent vaccine which will come soon? So you can post your answer again. Now, after having discussed the BCG and BCG efficacy and the role of BCG against leprosy, I think we have discussed a lot about BCG. Let's see that there are some more vaccine, and there are 3 more TB vaccines beside BCG that I think we should discuss, though briefly, because the data is not available that greatly. The first is the recombinant BCG. So, Dr. Sumita, what is the recombinant BCG vis-a-vis BCG? How does it differ?
Well, this is also known as VPM 1002. This is recombinant in the sense the gene which, the urease C gene, which is there in the regular BCG, is replaced by listerolysin. So what happens is that the ability of the phagolysosomes to destroy the bacteria is much better. Therefore, the efficacy of this is, it's a much stronger preparation, more immunogenic, and therefore it will give a much better response. That is what is surmised, and that is what the initial trials also have shown. So
Correct.
this
So
is
the
now
phagosome that is formed when the BCG is taken by the phagosome as compared to a normal BCG, because it cannot lyse that phagosome, it cannot expose all the antigen to the surface. Whereas here, because the gene has been now listerolysin, it breaks it, so all antigen can go to the surface and equally connect to CD4 and CD8. So a better antigenic response. I mean, that is what is probably think. Dr. Praveen, what is the advantage of this RBCG then over BCG in the form of safety or in the form of efficacy?
They will be more immunogenic. At the same time, they will avoid the systemic side effects which are associated with the live attenuated vaccines.
Correct. And there'll be lesser local side effect than local BCG
Local side effects will be much less.
All right. Dr.
And
Vijay.
stimulation of adaptive and innate immunity both can
All right.
happen.
Dr. Vijay, any trials are going on? Are you aware of any trials with RBCG?
Alluding to what Sumita and Praveen said, it is supposed to be more immunogenic. However, in the phase 2 study, they found that immunogenicity was not higher than the BCG when measured in terms of T cell response, etc. However, that does not, I mean, there is no linear correlation. So maybe efficacy, it may work as good. The biggest advantage is safety-wise. It is supposed to be more safe in newborns born to HIV exposed mothers as compared to your conventional BCG, with the risk of BCG adenitis or BCG ulcer, etc., is higher. Now, apart from this phase 2, it is undergoing phase 3 trial in African countries. It is being tested in EPI schedule for prevention of TB in newborn baby like your BCG. Then in India, there are trials which are looking at prevention of TB disease in close contacts, and then again reactivation of disease in adults who have been cured of tuberculosis. So once you have
phase
data,
3 trials
definite
are
data
going
on
on.
this,
One is
it will
prevention of
definitely be
reactivation, which happens in 5% of the adults who have just finished AKT. Second is in contact to prevent them from becoming IGRA positive. And the third, of course, is to replace BCG by RBCG in the newborn. Okay, the second new TB vaccine that we have is the GSK's TB vaccine, one of the most promising, which has already a very nice phase 2B trial on efficacy available. So, Dr. Sumita, what is this GSK's new vaccine?
That's M72, which has the adjuvant AS01E, which is also present, which they have also used for the other vaccines. So
Zoster vaccine.
Zoster vaccine, as well as their malaria RTS-S vaccine. This is actually a subunit vaccine wherein it has two different antigens. That's MTB32A and 39A. Basically, this is being tried.
These are recombinant proteins.
Recombinant, yes.
Yes.
Basically, this particular vaccine is being tried out as a method of protecting those who are already infected before they develop disease. So the IGRA positives have been taken into the trial, which is going on in South Africa. The phase 3 trials have started in 2024, and hopefully over the next 4 to 5 years, we will have the response to this vaccine.
So the phase 2B trial was done in 3 African countries, namely Kenya, Zambia, and South Africa, where almost 3,500 plus 18 to 50-year-old people who are IGRA positive were followed up in a placebo-controlled manner to see how many of them progressed to disease vis-a-vis placebo. And to utter surprise, the efficacy was 54% at 2 years follow-up, and 3 years end of the study has been published very recently, where it was shown that the efficacy persists at 49.7%. That's almost 50%. I think this is a great advantage, that if you can prevent progression from infection to disease in 50% of people, not only they will not need AKT, but they will not spread the disease. And it is now said that even when you breathe, you can infect your next person. You don't have to only speak or cough. Even when you breathe, you can infect. So I think less the infections. So the entire focus from treating disease patients and tracking them is to treat infected people who are otherwise so difficult. You can't keep on doing IGRA of everyone. So if you give a vaccine like this, that's going to be very useful. So, so that is the beautiful vaccine that we have. And the last vaccine that we have, oh, what happened? Okay. And the last vaccine that we want to discuss, but before that, I will have the some of you gave the correct answer to the quiz third question. That is B Yamagata as compared to B Victoria. As B Yamagata is not shown to be circulating for last 3 years consecutively in all the seasons, that has been the one which has been asked by WHO to be removed. Now we go to the fourth question before we discuss the last MTB vaccine. And after that, I will take the fifth question. So the fourth question is, which was the strain in the oral typhoid vaccine that was briefly available in capsule form in India? I repeat, which was the strain, typhoid strain in the oral typhoid vaccine that was available in capsule form in India? So, Dr. Praveen, the last question, very, very promising, because Indian manufacturer Bharat Biotech is pursuing this MTB vac. So what is the MTB vac?
MTB-VAC is a particular vaccine strain which has been developed in Zaragoza, Spain by BioFabry Pharmaceuticals by Dr. Carlos, and Bharat Biotech has entered into agreement with them to test it out in India and see whether it works. The advantage of this vaccine is that it is much more immunogenic. It is live attenuated vaccine, but it is much more immunogenic than the currently available vaccine as is claimed by them. And only after the trials we will be able to know that how well it will perform. They are claiming that it will again give protection against innate and adaptive immunity both.
So which means the CYTB intradermal test, which has replaced Mantoux test and is similar to doing an IGRA without bloodletting, the same two antigens, ESAT6 and the CFP110 coding regions are included in the MTB vac. In fact, MTB vac is actually a live, first time live human tuberculosis. So it has more than 1,000 antigens, the important being these two antigens. And that's why, unlike all other vaccines, like GSK's vaccine, which is two component, the BCG, which is actually a bovis vaccine, RBCG, which is just not same as BCG, but except only one little mutation change. Here, the MTB vac is a live human TB organism. So it will have a much more bigger repertoire of antigen to be published. Remember, when BCG was circulated for 13 years in laboratory to make it attenuated, more than 100 genes were lost. Some of them were 26-7% of them were common with the MTB. That's the reason why you can see the immune response is not as good, and that's why efficacy is not as good. We hope that probably MTB vac will have
that MTB will have all the antigenic load which is required.
So it has they call it rationally attenuated. They have it has undergone some deletion at 2 or 3 sites, the genetic segments. And as Nitin said, this is the only vaccine which is derived from Mycobacterium tuberculosis, MTB. So very promising vaccine.
So there are two insertional mutation intentionally, one in the FOP-P region and the other is FAD-T26 region, which makes the vaccine lose, which makes the organism lose its potency to propagate, induce cough, and to paralyze the immune system and not release the antigen for the immune system to work. So probably when these two mutations are there, there will be a better immune response. Time will prove. Is there any data, Dr. Sumita, with this vaccine, or is entering some phase 2, phase 3 data?
Phase 2 and 2B trials have shown the data that is in the HIV infected as well as in the adolescents and adults. So it has been done, and there is the data which is available, and it is now entering probably shortly into the phase 3 trials. So that has to be waited for.
So they are talking about this data from the other countries. In India,
no,
also
from BBIL.
Yeah, BBIL data, it's not yet published, but it's very promising. And
so
I remember on the World TB Day, they made an announcement that in 2025, they would be recruiting subjects for the phase 3 of this vaccine.
So I'm one of the members for the monitoring of the safety board for this MTB vac, and I'm a little private to what's happening. But anyway, I can't really more than that. But very promising from BBIL. And that, so most of you gave the correct answer that you have TY21A as the strain in the capsule form, and it was also available in liquid form in the South America, Brazil, in fact, and a lot of other South American countries use liquid form, which had more than 90% efficacy. But that never came, and children used to be given capsule in the school. They used to keep in their pocket, forget to give it to their mom, not stored at 2 to 8 degree. Pediatrician loathed it because they were bypassed, and that's the end of the story of that oral TY21A vaccine. And that brings me to the last question for the quiz. What is the generic name of the latest anti-RSV, respiratory syncytial virus antibody, monoclonal antibody? What is the generic name of the latest anti-RSV monoclonal antibody? Please put it in the chat box. Well, I think I had all the questions that I had to discuss on the TB vaccine. I have discussed in the 1 hour that was allotted to me. If there are any questions in the chat box, Dr. Amol, can you please look into that?
Yes,
Meantime,
sir.
I will ask Dr. Kasi to make some remarks. Dr. Kasi, please. Unmute yourself, sir. Dr. Kasi, unmute.
He is unable to unmute.
Please, someone can unmute Dr. Kasi, please.
Yeah, I got it.
Yeah, okay. Sorry. Yeah.
Excellent session. Nothing less to be expected when Dr. Nitin is at the helm. Okay. Only one point I want to say that there was a lot of talk about BCG and the immunodeficient child, HIV.
Right. Right.
UK has changed its recommendations. Now they've changed their BCG. They give it at 28 days or later. In fact, there is also a newborn screening test for T cell deficiencies. It is called T cell receptor excision circles.
Tregs.
That get TCERS.
Yes.
That gives you an idea of the T cell count. And if these values are low, it's highly suggestive of T cell immunodeficiency. That is being used now in Britain for screening for
SCID.
in the newborn period as a newborn.
Correct.
Probably that may be very useful.
I only skid even in HIV exposed infected newborn
Yes.
babies.
You
So
can
give
do
me the T cell count.
No. One is T cell count. Other is a Treg that is talking about. When they have T cell deficient, the Tregs are not liberated in the blood.
Yes.
So they actually take the quantity of the Tregs. And if they are absent, that means the child is having SCID and don't give any live vaccine. So they differ BCG because there's no TB load in their country. In our country, people may not come back. So it may be good to give BCG, but only you will have some case of BCGiosis when it's given inadvertently to someone who has a SCID-like disease. So that's the only point. All right.
And
anyone?
One more is regarding
Yes.
BCGiosis diagnosis. What Dr. Sumita said was fine, but today in the genomic area, it's also essential to do a genetic test on your isolate and show that those deletions that are present in BCG are also present in your sample. That's also one of the criteria for diagnosing BCGiosis.
Yes. So that is the organism identification, but clinical suspicion
Yes.
would
Clinical
be,
was criteria there. But
absolutely. So
ultimately, to prove the diagnosis, you got to do these tests also.
contralateral lymph node, hepatosplenomegaly, pulmonary disease in a very young child who is very sick, then it is SCID, not very sick, it is MSMD, and family history is positive in many of these patients, and some of them have recurrent TB in the family, telling you this probably they are MSMD families, and some of the MSMD can be autosomal dominant. So that's the clinical scenario, very rightly pointed by Dr. Kasi, that when you do the molecular testing, it'll be, in fact, today it's in the paper that for even TB, which is drug resistant, instead of waiting for the DST, which takes 2 to 3 weeks, you can do actually a molecular targeted panel. And in fact, JJ has already started, KEM is starting very soon in Bombay, and I'm sure all of us have privy to a private lab to doing that, and it costs something like 8 or 10,000, much cheaper than doing a 14 drug DST, which may cost 15 to 18,000. So from that point of view, so from that point of view, we are moving to like you are doing molecular diagnosis of so many infections, even in TB, to quickly diagnose drug-resistant TB. I think we are doing. It will be great to do this type of tests. All right. Any other last comment from the three panelists? First, Dr. Yeble.
So, I mean, we have not had a good vaccines for last almost a century. 1921 was the year when BCG was introduced. But now there are many candidates. Some of them have reached phase 3 also. And essentially, when you talk about BCG vaccine, you look at 2 or 3 things. One thing is its safety and immunogenicity in both HIV exposed and HIV unexposed infants. Number 2, you look at prevention of infection, prevention of disease, and prevention of recurrence. It would be ideal to have a vaccine which is safe in HIV exposed babies, which can prevent infection also, and will be obviously effective in preventing disease and recurrence. But the day is not far where our PM Modi's dream comes true, though the path is not so simple and straightforward. Let us hope that we are able to control this disease.
All right, Sumita, parting remark.
Well, the future looks so exciting. A whole lot of, apart from the 3 vaccines which we discussed today, there's a whole gamut of vaccines which are in the various stages of development using various platforms, mRNA, etc. So many vaccines. So a lot of excitement, a lot of hope for the future. But I think we have to be cautious and remember that BCG is still something which we have to revere and value and ensure that every child gets it. So that's probably at present our one step towards ensuring we eradicate tuberculosis. The targets are probably 2030, but whether we can achieve it or not is secondary. I think we just have to go ahead and ensure that BCG is not missed for any reason.
Praveen.
Yeah, from practicing pediatrician's view, I'm really concerned about the errors that are happening, and one more error to prevent. To prevent is the mixing of using hepatitis B as a diluent instead of the BCG diluent. We have even seen that happen. So that is one point I want to make, that be very careful when giving it together. And second point is that BCG still remains the gold standard to give as of date, but path ahead looks very promising. And we all have to be very alert in at least diagnosing the cases which we have in hand and taking them to a conclusion.
Sushant, unmute.
I am not an expert in vaccine, but all what has been discussed is
Sushant, make your
practical and true.
unmute yourself.
Yeah, he's unmuted. Go ahead. Yeah.
Yeah. All what is discussed is very much practical and true. Just one point that what we discussed about the adult BCG vaccination. So they did a programmatic setting. Now they have rolled out for the country.
Correct.
So as Dr. Sumita said, it is definitely at present voluntary. It is not a compulsion, but they are now doing a door-to-door campaign. At least in Mumbai, they are going door-to-door and they are offering BCG vaccination to all those 5 or 6 criteria which are there. And the whole, what you can say, the idea behind it is, like we said, right now we just have only statistics. But what they have shown is if this works, then we will get down the mortality by more than 20% of TB. That is one thing. And second thing is the costs per patient into the number of patients we have for the country would go down. So this is just an estimate. So
Sushant, I have one question. Is there any built-in mechanism to study the impact of this whole campaign?
So whoever they are vaccinating, okay, they are taking their details. Yeah, they are taking their details, the address and everything. Very soon there will be it is going to be uploaded also on Nickshare. So the link is
they will probably compare it with the historical control to see what is the rate of infection to disease or disease to again a re-disease. I think that's a good idea because now in today's electronic time, it's so easy to capture all the data. I will just end before I hand over mic back to the office bearers. Again, from the bottom of my heart, thanks to the organizers for giving us this wonderful opportunity. All the 3 panelists and Dr. Sushant as the expert for sparing your valuable time. I was in one of the seminars, Sushant, I don't know, true or false. I'm going to speak to GSK. I was told that the GSK's MTB vaccine, which has shown so promising 50% result in decreasing infection to disease progression. The phase 3 trial cannot be done because the ASO3E adjuvant, because it's being used in the Zoster vaccine, other vaccine, is not available for a TB vaccine trial to begin. If that is true, I think that will be really very sad. If not true, then maybe we can prod GSK to see that they gives at least enough for the people to have a trial going on, because till the time we have MTB back or something else, if this can reduce 50% infection from progression, I think that'll be worth it. With that note, I would like to thank all the participants who have joined either in the Zoom here or on the YouTube live channel for hearing us patiently. I hope you like the way we conducted this, starting with the disease burden, then a dialogue and some quiz in between to keep the whole thing alive. I promise on 7th of March, we'll come out with another important vaccine to be discussed. I hand over mic back to the organizers.
Thank you so much, Nitin sir. That was a fantastic session. I guess all the comments in the chat box itself is a testimony to the session today. Just a couple of questions which were there in the chat box.
Yes,
if
please.
I have given BCG vaccine accidentally subcutaneously, can I repeat intradermally again at the same spot?
That's not required because that will work, though there'll be little more side effect like BCG lymphadenitis.
And if you want to repeat the BCG vaccine, like how we discussed after 6 months, again, do we give it in the left upper arm?
Yes, always in the left upper arm.
Okay, sir. And the last question was, if CYTB test is positive, should we start AKT right away or we have to go for the microbiological test?
It only tells you that somebody is tuberculized. Yeah, sorry, Vijay, go ahead.
Cutoff is less, but the interpretation is same as your PPD.
So as much as you do
infection, but not disease. It will not rule out. You have to rule out active disease.
You will try to investigate further. Now, as I said, in fact, Hinduja Hospital, we are trying to establish tools instead of the gastric lavage as a diagnostic tool. If that happens, it will be so easy for the parents just to give the stool sample and if you do a gene expert. So idea is that you try to still prove, if you can't prove by a gene expert culture and there is strong evidence of TB, then you say probable TB and you treat. But otherwise, I think everyone is moving towards a bacillary diagnosis, even in pediatric patients.
Sushant is there. I want to ask Sushant. Sushant, WHO has recommended stool and the mask N95 mask sample and saliva also they are looking at. Saliva, I think WHO has not yet approved. But what about the stool and the N95 mask aerosol sample?
So they are recommended two. One is stool and one is nasopharyngeal.
Ah.
The mask they are still validating. They have not come up with the validation. Stool definitely they have recommended. And ICMR, in fact, the NIRT Chennai is gathering our own country data, and very soon, they will come out with the recommendations in the national program. The reason why we had not implemented as yet, because initially when the WHO recommended 2 years back, the pre-processing of stool was a little cumbersome process. There were 2-3 techniques, and they were not able to confirm which technique is the most suitable for pre-processing. But
Correct.
now only one technique has been approved, and even the ICMR has got good results. So maybe once we have our own ICMR data, it will come in the national program.
Yeah.
But
So
till the time, if it is available in private and the patient is affording, we can do it.
And
so
I
like
believe though the yield is low
like the
as
fecal transplant in the past, we were doing in Hinduja for patients with inflammatory bowel disease. You collect stool of the relatives which are very healthy, but it's a very messy process to make that what you call lysate out of the stool and then inject it to the scope. So I mean it's something which people don't like to do, but someday we'll have to do. We are trying to establish that in Hinduja by doing 10 patients, both the gene expert and stool, and see which comes more positive. But it's actually supposed to be even more sensitive than the gastric
No,
lepers.
the yield of these samples is slightly marginally lower than your gastric aspirate, but the utilization is
Yeah.
more. So that would compensate.
All right.
Yeah.
To
Thank you,
the
sir, for-
organizers.
Yeah, thank you for patiently answering. I would like to wind up the session by asking Dr. Sheikh to give the official vote of thanks.
Well, thank you, entire team, right from Nitin Shah sir to Sushant Mane, Yevle sir, Sumitra Naik madam, and Praveen. It's been a wonderful session. We keep on learning, though we feel BCG it's a vaccine, but it's a lot to learn, right from advertent dose, site, BCG, repeat BCG to latest MTB vac. So thanks a lot, sir, and a great learning. And we continue to learn from you all in future also. We'll see you again on March 7, same time, same day. Good night. Thank you all.
Thank you.
Good night,
Thank you,
everybody.
sir. Good
Thank
night.
you.
Good